Hello, today we're going to be covering the heart. So the heart is it's kind of a triangular shaped organ. It's not the classic idea of a heart that we think of. Oh, I don't have a color on my pen today. Here we go. Like this. Hearts tend to be shaped more like this, right? Kind of like a fat triangle. It lays in the middle of your thoracic cavity, with two-thirds of the heart actually sitting more to the left side of the body than on the right. However, in some people, it's kind of rare, the heart can be more localized to the right side. The apex of the heart is close to the diaphragm, so this would be the apex. The base is up high. Okay, and the shape and the size of an individual's heart is about the size of your fist. So if you look at your hand and you close your fist, that's about the size of your heart. Of course, the bigger your body size is, the bigger the heart's going to be. So here's an example of an artist's rendition of the heart sitting within the thoracic cavity with the major blood vessels showing. So we're looking at an anterior view, the front of the heart, and what are the important elements to look at? Over here are the atria, the purple sacs here, the right and the left atrium. They can also be called auricles, okay, which you may see later on in the lecture. The auricle, it's the same idea. It's supposed to be because they look like, kind of like elephant ears. Let me change my pen color here because this isn't working so well on purple. So the auricles look kind of like elephant ears. On the left side here, it looks smaller because we have the left pulmonary artery and the aorta blocking the view of the left atrium. The right and the left ventricles are the larger compartments. So here's the right ventricle, here's the left ventricle here, and they're separated by a big piece of connective tissue interiorly, okay? We'll see that later. Other very important elements to understand and to remember about the heart are going to be the following. The superior and inferior vena cava. So here's the superior and the inferior is down here. Okay, what this does is it brings, I'll just do INF, vena cava. These are the blood vessels that bring blood back into the heart after it's dropped off as much oxygen as it can into body systems. Superior is coming from the head, inferior is coming from the body, okay? So everything below the heart. Superior also brings in circulation from the arms, the upper part of the trunk, the neck, and so forth. The pulmonary artery takes blood out, okay? It takes deoxygenated blood out into the lungs. Now, what I'm going to do is I'm going to start annotating deoxygenated blood with blue and oxygenated blood with red, okay? So actually, I drew these incorrectly for the vena cava. Oops, let me get my eraser going here. The vena cava is both superior and inferior. They contain low oxygen blood. So blue equals low oxygen, okay? The red for the rest of the slides are going to be high oxygen containing blood, okay? So the pulmonary artery takes blood out into the lungs, okay? And that's why it's pulmonary, okay? This is the only place in the body where an artery is carrying deoxygenated blood. In the circulatory system, we typically say veins carry deoxygenated blood, arteries carry oxygenated blood. But the reality is the designation of artery and vein doesn't have to do with oxygen levels, okay? Arteries carry blood away from the heart. And so this is a little bit of a review of the circulatory system. So arteries, always carry blood away. Most of that blood is going to be high oxygenated blood because most arteries are taking blood to the body system. So over here we have the brachiocephalic trunk. Okay, this the brachiocephalic trunk takes blood out to the head, which is the cephalic portion, and then out to the arms, which is the brachial portion. Okay, you have the left common carotid taking blood up to the head again, and then the left subclavian. So these arteries all are taking oxygenated blood out. On the other hand, when we get to the pulmonary artery, right here, what I was just talking about, the pulmonary artery is taking deoxygenated blood out to the body, out to the lungs, where CO2 can be delivered to the alveoli, and the CO2 can be removed from our system, and oxygen can attach itself to red blood cells as they're circulating through. Okay, so arteries typically blood away from the heart, veins, blood is going to the heart. All right. Other very important pieces of vasculature to pay attention to are going to be the coronary artery and the coronary veins. The coronary arteries and coronary veins are bringing blood to the actual cardiac tissue itself, to keep the cardiac tissue healthy, to provide it with nutrients, to provide it with oxygen and remove CO2. So we have the coronary artery and the cardiac vein, and then we have the branches of the left coronary artery and cardiac vein. So you have the right and the left. Very, very important. The great cardiac vein is bringing blood back into the system. All right, and when we look at the posterior side, we're going to see some other vasculature that helps to support the muscle tissue of the actual heart itself. Something to understand, and this is absolutely essential, I'll get to this in a minute, is when blood is circulating inside of the heart through the atria and through the ventricles, that blood is not delivering oxygen to the heart at all. There are membranes within those chambers, within the atria and the ventricles, that block gas transport. So the blood brings oxygen and nutrients and removes waste only in the arteries and veins on the outside of the heart. Blood on the inside of the heart doesn't nourish the heart at all. Okay, so we're going to briefly talk about CPR. Since the heart lies between the sternum, all right, so that's that big bone right in front, and our body, which the back of the body would be the thoracic vertebra. The heart, when it stops beating, and it's surrounded by bone, and the sternum, remember, the sternum's kind of springy. There's cartilage in there associated with it, right? Associated with the ribs. By applying rhythmic compressions to the heart via the sternum, you can introduce a rhythmic compression series of events that can keep blood flowing through the system if the blood stops. So that's cardiopulmonary resuscitation. What it does is it helps maintain blood flow to tissues, especially the brain, okay? And this procedure can be absolutely life-saving. One of the things that is essential is that we ensure that blood circulation is maintained to the brain at all times. If blood circulation stops to the brain, well, then we're going to have a problem, because neurons are extremely metabolically active. They require a lot of oxygen. They undergo tons of ATP production in their mitochondria. They have a lot of mitochondria. And so without that oxygen, brain cells die pretty quickly. So ensuring that blood at least is moving around through the system is a big deal. Providing oxygen and removing CO2, you have to get rid of that too. Now, if the person's not breathing, how do you get oxygen in there? Well, it turns out that oxygen levels actually don't go down to levels that would cause cell death pretty quickly. As long as the blood keeps circulating around for at least a good 10 minutes, those cells can be maintained in the brain, all right? After 10 or 15 minutes, it does become essential to start doing breathing for the individual. If EMTs are present on the scene, they typically have a face mask that they use to pump oxygen or just pump air via positive pressure into the respiratory system, and they maintain the rhythmic compressions of the heart to ensure that oxygen and CO2 are being moved around through the system so that cells may maintain their nourishment via oxygen and eliminate CO2. Okay, so the heart chambers. Two upper chambers are the atria, the receiving chambers, right and left, and the two lower chambers are the ventricles. These are what we call discharge chambers. They discharge blood out into either the pulmonary system, the lungs, or out into the body. So let's talk about what is the walls. What are the walls of at least the ventricles made of? Cardiac tissue, as you may recall, is called myocardium. Myo for muscle, cardium, heart, right? So it's heart muscle. Of the myocardium, on the inside, we have something called the endocardium. This is what I was talking about lining the interior of those heart chambers. So the actual muscle is myocardium, which is also included in the atria. It's just the myocardium's thinner in the atria. The endocardium is a really smooth connective tissue that lines the chambers that helps maintain smooth blood flow actually through the heart. If there is an inflammation of that tissue, it's called endocarditis, which disrupts the flow of blood through the heart and actually makes it hard on the myocardium. Endocarditis, the inflammation inside the heart, causes the heart to start contracting sometimes irregularly, and it can also cause the heart to increase its heart rate or decrease depending on the degree of endocarditis. So here's a picture, an artist rendition of the internal anatomy of the heart. So we've been talking about the muscle, so let's start with that. Here are the atria. Here's the right atrium right here. Here's the left atrium, oops, right over here. Sorry, I was pointing out the pulmonary veins. The atrium are always indicated in purple because they have low oxygen. The ventricles, for some reason, they're always indicated in red. I think that's because even though we know that they only, well, the left atrium does have oxygenated blood. The left ventricle has oxygenated blood. For the most part, if you just divide the heart this way, okay, this is low oxygen. This is high oxygen. I guess that's the best way to think about it. The colors kind of indicate localization. There's some other reasons the colors are the way they are. Don't worry about that for this class. You'll talk about that in Bio 16, though, when you get to Merced College. So when we look at the ventricles, you'll see that the myocardium is a little bit different between the right and the left side. You'll see that the myocardium is thinner on the right ventricle than on the left ventricle. Between the two sides is what we call the intraventricular septum, which is a nice thick layer keeping the right and the left side of the hearts separated from one another. What's happening here is you have a separation of low oxygen, right, from high oxygen. And that's a big deal for mammals because the only way we get oxygen into our system is through breathing, your respiratory system, and through circulation, okay? We're not like a frog that can sit in water and absorb oxygen through our skin, right? This is the only way we get oxygen to our body. So it's essential for mammals to separate the areas where there's low or no oxygen from the areas that do have oxygen, all right? And that would include your atria here. So we have the intraventricular septum separating the right and left ventricles. Now let's talk a little bit about how blood flow is maintained through the heart. The right atrium receives blood from both the superior and inferior vena cava, even though they don't have it in this picture. Inferior would be coming in from the bottom. When we look at a posterior visualization of the heart, you'll see the inferior vena cava more obviously. Blood enters in through the right atrium and then circulates down into the right ventricle via the tricuspid valve. Okay, the tricuspid valve is a valve that allows blood to go in only one direction. When the valve closes, blood cannot go back up, all right? So I'm going to use, let's see if black works any better. Okay, blood can't go back up once this valve is closed. What happens is once this valve closes, blood may circulate out to the pulmonary arteries and the pulmonary arteries out to the right and left lungs. The pulmonary semilunar valve opens to allow blood to exit the right ventricle. Blood will go out and circulate through the lungs. We don't have that in this picture, but don't worry about it. And blood comes back in through the pulmonary veins. Now, there are, in addition to left pulmonary veins, there's a right pulmonary vein as well. And I'm going to see if I can make my pen any thicker here. It would be nice if I could. Hello, pen. All right, I guess not. Right and left pulmonary veins, bringing blood back into the left atrium here. They're only showing you the left pulmonary vein, but there is a right because we have a right lung as well, right? Blood comes in through the left atrium, exits down into the left ventricle via the bicuspid valve here, or the mitral valve. This is also called the mitral valve. Okay, then blood circulates out through the aortic semilunar valve, out to the aorta. That's what I love about this name, because it tells you where it's going, aortic. So the semilunar valves are cool. The names of them are great because it tells you where the blood is going. So the aortic semilunar valve, blood's going out to the aorta. Pulmonary semilunar valve, blood's going out to the lungs. So it's really helpful in that way. So the blood will be coming out and then out the aorta up through the subclavian, brachiocephalic trunk, and so forth, carotid. So the structure and the function of the myocardium depends on the health of the myocardium. So I was showing you in the last picture the pulmonary arteries, and not pulmonary, the arteries that feed the heart itself, the coronary vessels, the coronary veins, the coronary arteries. If you look over here in this picture, you'll see the endocardium, okay, the inside of the heart. This is that connective tissue on the inside that does not allow oxygen to pass into the myocardium, right? Instead, we have this visceral pericardium over here, and this is where we're going to find the coronary blood vessels. So oxygen enters through the coronary arteries, and the coronary veins take away carbon dioxide that's generated by the cardiac muscle cells. Now, these muscle cells are contracting every minute, every second of every day that you're alive. So these cells require a tremendous amount of oxygen to generate ATP. They also require a tremendous amount of glucose for glycolysis, but they can also run on fatty acid metabolism and protein metabolism. Fortunately for the heart, there is a little bit of fatty connective tissue around where the blood vessels are. Good placement. That's a nice buffer area that, number one, compression won't affect very severely the coronary vessels. So the fatty tissue surrounding them kind of buffers them from movement. And the other thing is that the heart has its own little fat reservoir surrounding it. Now, when individuals have too high of a body fat content, that heart layer can get thicker and thicker over the surface of the heart. And that heart layer, or that fat layer, can end up being a problem if it's too thick. So coronary heart disease, one of the characteristics is a lot of fat around the heart. Outside of this fatty layer, we have a pericardial space, and then we have the parietal pericardium, which we'll talk about in a little bit. Okay, these are the tissues outside of the heart. Between the two, though, between the parietal space, well, not, inside the parietal space, I should say, between the visceral pericardium and the parietal pericardium, we have fluid. That fluid allows for the heart to contract smoothly. It's like, I guess you could say it's kind of like a lubricant. The heart can contract but not build up friction with the area outside of the heart. Okay, so what does friction do? If you put your two hands together, so do this as an exercise by yourself, sitting at your computer while you're listening, put your two hands together, rub them, you'll notice that your hands start heating up. They heat up because of friction, all right? And that might be good if your hands are cold and you're outside on a cold day, or if you're skiing or something, but it's not so good for your heart, or especially friction generating heat adjacent to blood vessels. What would happen to your blood if it starts heating up, right? Your whole body would heat up. That wouldn't be good. So the pericardial space, the fluid in that space, allows for some lubrication to occur so that friction doesn't build up and you don't get extra heat generated by the process of heart contractions. All righty, moving on. So the pericardium and pericarditis. Pericarditis is a disease of the pericardium. We'll get to that in a minute. The pericardium, as I just pointed out, is a two-layered fibrous sac that has lubrication between the layers. The inner layer actually surrounding the heart and surrounding the fatty layer that contains the vascularization that feeds the heart is called the visceral pericardium or the epicardium. And the outer layer is the parietal pericardium. Pericarditis is inflammation of the pericardium. And this is kind of a weird thing that happens is sometimes when we get dental work done and your gums bleed, bacteria from our mouth gets into our bloodstream. And sometimes that blood gets associated with the pericardium. So the blood is circulating around. Let's go back one slide, if this will let me. The blood will circulate out of the coronary vessels, and bacteria can actually end up in this pericardial space. All right. Well, that is a nice, healthy, happy, salty, warm environment that the bacteria love, and they start multiplying. So pericarditis is inflammation of the pericardium, and dental pericarditis is brought on by oral flora that get into that layer. So what ends up happening is the inflammation inside of the pericardium allows or it influences a buildup of fluid between the visceral and the parietal pericardium. That fluid buildup puts pressure on the heart, causing more fluid buildup to happen. And that's called cardiac tamponade. The cardiac tamponade is the compression of the heart caused by the fluid building up, between the fluid building up in this pericardial space. And so that's very dangerous because it affects how your heart functions, all right? And so typically what will end up happening is the symptoms that first occur is breathlessness. Your heart is beating very quickly. It's undergoing tachycardia. And patients say they feel like there's pressure on their chest, like an elephant is sitting on their chest, which doesn't sound very fun to me. So how do they treat this? Typically with IV antibiotics. They're very, very aggressive about treating pericarditis, especially when it's bacterially derived, because that has a profound effect on the heart. Okay, so let's talk about the heart action, how the heart contracts. Systole is the contraction of the heart. Diastole is the relaxation of the heart. And what's interesting is the atria and the ventricles swap off, or they rotate how systole and diastole works in the heart. So as the atria are contracting or undergoing systole, the ventricles are in diastole. And vice versa. When the ventricles contract and are undergoing ventricular systole, the atria are undergoing atrial diastole. So you have this back and forth process happening. The top contracts, the bottom's relaxed. The bottom contracts, the top relaxes. And the heart valves direct blood flow. As the right atrium contracts, it sends blood down. Oops, sorry. Oh, here we go. This is better. As the right ventricle or atrium contracts, it sends blood down to the right ventricle where it sits. As the atria is contracting, the semilunar valves are closed. Okay, same thing happens over here. As the left atrium contracts, blood is sent down to the left ventricle. Semilunar valves are closed. During the ventricular contraction, the atrioventricular valves close and the blood goes out through the semilunar valves right here. So this back and forth action between the semilunars and the bicuspid and tricuspid valve, or the mitral and the tricuspid valve, are important because it keeps blood flowing in one direction, in then out, in then out. But it also allows for, it's also, I guess you would say, rhythmically organized such that the lungs are able to recharge the blood with oxygen and release CO2 into the environment. So our heart contraction, or systole and diastole, also is coordinated with our breathing rhythms, which we will talk about in a separate chapter. So the four valves keep blood flowing through the heart. They prevent backflow. The two atrioventricular valves, we also call AV valves, and the two semilunar valves. Now, here's one thing that can sound confusing. This confused me when I was younger. We call this, so the semilunar valves don't look anything like a moon. All right. I guess you could say that looks kind of lunate. I just learned that, I just memorized semilunar in terms of you have things that look kind of moon-like here. All right. The tricuspid and the mitral valve looks more lunar. And in fact, I used to make that mistake when I was a student too. Just remember that the semilunar valves are always letting blood out of the heart. Atrioventricular valves define exactly where the blood's flowing, from the atrium to the ventricle, right and left, atrioventricular valves. I usually don't call them tricuspid and mitral. I just stick to atrioventricular, but you should know tricuspid and mitral because that might show up on a quiz someday. All right. So the tricuspid valve, like I mentioned, has an opening. It opens to the right. It's the opening of the right atrium out to the ventricle. Bicuspid valve, the mitral valve, is the opening from the left atrium to the ventricle. And this is just a picture showing you the mitral valve when it has stenosis, mitral valve stenosis. So stenosed valves are narrower than normal, and it slows blood flow from one chamber to the next. Mitral valve stenosis can come from a whole bunch of, you can get that for a bunch of reasons. The number one reason is aging. That's one thing that none of us can stop, the clock. Aging just over time, that tissue gets kind of stretched out and calcium can bind to it because we have calcium floating around in our blood. So stenosis is the dysfunction of the valves in the case of aging just because of time. Mitral valve stenosis can happen because of smoking. The heart's working harder, pushing more blood through there. That blood pressure goes up, causing problems for the valves. So the mitral valve is usually the most likely valve to first suffer what we call prolapse. The stenosis leads to the valve not entirely closing, so you may have a bit of backflow. So, here we go. So mitral valve prolapse happens when the mitral valve doesn't close completely, and instead of having this flat surface, it has this bent surface here, and this is the stenosis, which allows blood to come back up into the left atrium as the ventricle contracts. Blood still will go out to the aorta, okay? It'll still leave the left ventricle out to the aorta, but some of it will go back into the atrium. And this is a leakage, all right? Blood going backwards is basically leaking. And what that means is blood coming in from the lungs backs up. And that causes problems with the lungs itself later on in life. Okay, so the pulmonary semilunar valve is at the very beginning of the pulmonary artery, and the aortic semilunar valve is at the beginning of the aorta. These valves, they do have a lot of pressure put on them by the ventricles, because especially the left ventricle. The left ventricle is a really powerful part of the heart. And so when there is incompetent or leaking valves, some of the blood will leak back into the ventricle, and that's not good either. When that happens, you have backflow in the heart. It backs up to the atria, then it causes incompetence of the mitral and tricuspid valves. And basically, it's a gradual weakening of the heart. So why does this happen? Again, because of stenosed valves. These valves are narrower than normal. Stenosis of the valves, again, can be due to calcification. It can be due to smoking, high blood pressure. It can also be due to rheumatic heart disease. Rheumatic heart disease comes from inflammation that came from a streptococcal infection. So strep throat can lead to rheumatic fever, which damages heart valves. Mitral valve prolapse, which we just looked at a few minutes ago, is the incompetence of the valve to keep blood in the left ventricle. Blood comes back up to the left atrium, which then can backflow back into the lungs. All right, so that's enough about the valves. When you get to Bio-16, we do talk more about the valves, and you will be doing a heart dissection where we look at how the valves in a healthy heart, keep blood from flowing backwards. And every now and again, we end up with a heart that had a prolapsed valve. And that's kind of interesting because you could see how it was incompetent. So let's talk about the heart sounds. So when a nurse listens to your heart or a doctor listens to your heart, what they're listening to is basically that lub-dub sound, that thump-thump. The first sound, which they call the lub, is caused by the vibration when the AV valves close, the atrioventricular valves close. So that's the first sound that they hear. And the second sound, the dub sound, happens when the semilunar valves excuse me, relax. Okay. And so what you're hearing is basically the valves snapping open and close, open and close. It doesn't seem like it should sound like that, but if you think about the way I thought about it is you're not physically hearing of the heart valves closing or opening. What you're physically hearing actually is the lump of blood going from one chamber to the next. So you hear lub as blood comes from, let's say, the right atria down to the right ventricle, and then the contraction pushing the blood out to the lungs or to the body if you're looking at the left side of the heart. Heart murmurs are abnormal heart sounds that can be caused for a few different reasons. In young children, a heart murmur can happen because of a incomplete closure of something called the fossa ovalis. That is a hole between the right and the left atria. So when we're babies, when humans are in utero, I always like talk about us, right? But when humans are in utero, and this is true for most mammals actually, there is a hole that connects the right and the left atria. In utero, it doesn't matter as much separating the oxygenated blood from the deoxygenated blood, because the blood that the fetus is getting is from mom. So this fossa ovalis is a little hole that connects the right and the left side of the heart at the atria level. And as babies are born, sometimes that hole doesn't completely close up. So what ends up happening is doctors can hear, using a stethoscope, a leaking of the blood going from the right to the left ventricle during the atria during ventricular systole. And so that sound in young children usually goes away by the time they're 2. And they call that a heart murmur. That's a pediatric heart murmur, an infant heart murmur. As we get older, heart murmurs usually happen because valves are failing. So blood is flowing backwards from one chamber to the next. So instead of hearing thump, 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 you'll hear thump, thump, shh, thump, thump, shh. And it's a very quiet hissing sound. It's kind of interesting to hear. Unfortunately, I don't have any examples, but you might look for it online. Maybe I can find a video. If I find one, I'll post it for you. Oops. So the heart itself acts as 2 separate pumps, the right and the left side, performing different functions, taking deoxygenated blood out to the lungs for recharging, and taking oxygenated blood out to the body to deliver oxygen for cellular respiration. So what is the sequence of the blood flow? I'm not going to read this slide, but it's important for you to remember and maybe memorize the direction of blood flow through the heart. So venous blood from the superior and inferior vena cava enters the right atrium through the superior, okay, there you go, inferior vena cava, passes through the right atrium through the tricuspid valve or atrioventricular valve down to the right ventricle. Blood from the right ventricle goes out the pulmonary semilunar valve out through the pulmonary artery to the right and left lungs, where it just splits off. And it's random which direction a red blood cell is going to go. There's no there's not like a gate saying this group's going to the right lung, this group's going to the left. Blood circulates through the lungs. CO2 leaves. Oxygen hops on the heme groups of the red blood cell. Blood then from the lungs goes into the left atrium, passing through the mitral valve, down to the left ventricle, where then the left ventricle contracts, it undergoes systole, and pushes blood out the aortic semilunar valve to the aorta, where it goes to the brachiocephalic, the subclavian, which is number 3, and the one in the middle, I can't think of it, the carotid artery. Sorry, I'm trying to remember 20 things at once. and distributes blood. If it goes through the aorta and doesn't go to the brachiocephalic carotid or the subclavian, it goes down to the rest of the body. And so this figure is showing you the direction of blood flow, okay? The aorta going up to superior circulation, that would be your brachiocephalic, carotid, definitely the carotid coming up to systemic capillaries up in the head, subclavian as well, or circulation going into the inferior portion of the body. So we call this loop here going down to the body or up to the body, out from the superior and inferior part of the body, systemic circulation. When blood goes out to the lungs, and here's the split right to the left, and then comes back into the heart, we call that pulmonary circulation. So pulmonary and systemic circulation are isolated from one another. So coronary circulation, that's the blood supplying oxygen, nutrients to the heart itself. Remember, we looked at those coronary arteries and veins in some of the earlier slides. Blockage of coronary circulation leads to a process called myocardial infarction, which is known also as a heart attack. So blockage of these coronary arteries, which are pretty small compared to other arteries in the body, actually blocks blood from going out to the myocardium, and it starves it for nutrients. So let's look at the anterior. Okay, so here's anterior view, and here's the posterior view of the heart. All right, so you can see the right coronary artery branching off, supplying the heart with nutrients. All right, and this is the ventricle. We're not actually paying much attention to the atria right now. Don't worry about that. All right, here in the posterior side, you can see, so here's the blood going out to nourish the heart. Where you see it a lighter color, that's on the posterior side. The darker red here indicates anterior circulation. The lighter orangey color is posterior circulation, okay? Now over here, we're looking at a posterior view of the heart, and we see the coronary sinus. This is where blood is returned out here to the right atrium, okay? So blood circulates back out to the right atrium over here through the coronary sinus. Actually, I lied to you. That is an anterior view. Ha, Dr. Val made a mistake. There is another coronary sinus on the posterior side that's reduced. I am so sorry. Okay, guys, see, even professors make mistakes sometimes. Part of what's happening over here is, number one, I'm looking at the complicated coronary artery pattern here, and I wasn't matching it with the cardiac vein. So my apologies. Here's an example of where Dr. Val got it wrong. But what did I do to correct it? Number one, I'm going to apologize. My bad. But one of the things you should always do when you pay attention to a figure is look at the landmarks. Right atrium, left atrium, left atrium. And that's why I was looking at the sinus and then going, wait a minute, it does circulate back to the atrium. And that's because we have the light blue. That is the posterior side. It is the posterior side. See, I'm right. I just was looking at the wrong side. Man, maybe I should re-record this part. Let's move on. Okay, so atherosclerosis is a type of hardening of the arteries. We've heard about hardening of the arteries and cholesterol levels. So what ends up happening is cholesterol, fats, and lipids in our bloodstream actually get together with calcium to form these plaques on the inside of our arteries. And this includes not only the arteries on the surface of the heart, but all the arteries of your body. So it's interesting because we think of this like kind of like butter in your arteries. These atherosclerotic plaques actually are more like little stones. When you look at a series of atherosclerotic plaques that have been removed from a cadaver artery, they actually, when you drop them into a pan, they make a sound. They're like little rocks. They partially or totally block blood flow if they build up to large enough little stones, basically to large enough plaques. Blocking coronary blood flow then blocks, let's say you have a block right here on the left coronary artery, there's no blood coming down to this region of the heart, which means that portion of the myocardium can actually die because there's no oxygen going there. The rest of the heart is okay, and it continues to contract until this region undergoes spasm and starts to die. That's when angina pectoris starts coming in, chest pains caused by inadequate oxygen to the heart. So angina is your heart's way of saying, hey, there's not a lot of oxygen going on here. So during a heart attack, what ends up happening is one region of the heart, if blood's not restored, this region of the heart becomes weak, it dies, and the heart is weakened. And sometimes if it's a large enough patch of the heart actually stops contracting because it interacts with the electrical conduction system of the heart, which we'll talk about in a little bit. So a regular healthy heart cardiac cycle, one that's not interfered with by mitral valve prolapse, or not mitral valve prolapse. Now I'm all upset. Through atherosclerotic angina, should normally be about 72 beats per minute, just average. That includes getting up and walking around a little bit. It includes sitting down. Each cycle, the contraction and relaxation, should take about 0.8 seconds. So it's less than a second for your heart to contract and relax, or not your whole heart, for your ventricles and auricles to contract separately. So the conduction system of the heart is what's regulating the contraction. So here's what's really weird, and I don't know if you guys have ever seen this. So you see a movie, right? And it's like an Indiana Jones movie, and some bad guy rips somebody's heart out, right? And it's pretty graphic, sorry. It's anatomy though, right? And this is like fake anatomy because it's in the movies. And the heart continues pumping. Well, the heart itself can continue contracting because it does have its own pacemaker system. The sinoatrial node is the pacemaker of the heart. The SA node itself is localized to the right atrium, and it receives input from centers in the brainstem, the rhythmicity centers in your brainstem. And so that's an autonomic function. So if you remember back when we talked about the autonomic nervous system, we don't actually have to think about contract, relax, contract, relax. That would be so distracting, right? I would forget. I'd die of, no circulation. But the sinoatrial node receives these constant kind of signals saying contract, contract. And the sinoatrial node, the pacemaker, which is embedded in that right atrium, right close to the superior vena cava, triggers a contraction in the atrial region, the right and the left atria. The atrioventricular node, which we'll see a picture of in a minute, receives the information that's traveling through the myocardium. So you have this contraction, boom, set off by the SA node. Myocardial cells start contracting. Then the contraction reaches the AV node, the atrioventricular node. That's located in the right lower portion of the right atrium, near the septum. That then acts as an amplifier. It goes boom, and it sends another contraction signal down to the ventricles via what we call the AV bundle. It used to be called the bundle of His. In older anatomy texts, it's called the bundle of His. And the bundle of His, it's not hist, it's hiss, like a snake, right? Goes down through the septum and permeates the ventricles, allowing communication among the myocardium in the ventricles. What does this look like? I like looking at the picture while describing this. So let's talk about this again. So we have information coming down from the brainstem, okay, regulating the pace of the heart. Now, the brainstem also is getting information as to how much oxygen is in our blood. It's actually measuring how much CO2 is in our blood, not so much oxygen, but CO2. That information is sent from the brainstem. So the brainstem responds. Let me make stem look better here. Brainstem responds, sends information down to the SA node. The SA node sends information over here to the myocardial cell saying contract. There's this separate branch that goes over here to the left atrium. So the right atrium contracts just milliseconds before the left does because you have this flow of information saying contract to the left atrium. The information travels down to the AV node. It travels through these small fibers, but also through the myocardium. The AV node is a large bundle of neurons, basically, that sends information down through the bundle of His. There's a right and a left branch that spreads out to the right myocardium and the left ventricular myocardium. And then you have these little Purkinje fibers, these little branches, that also help to communicate with the myocardium saying contract. So when you have contraction starting here, thump, the lug here, this region is relaxed because there's no conduction happening through the ventricular portion of the heart. When the signal does get down here, you have the dub happening, which means that this part is relaxed because the information has already flown down with the blood. Isn't that crazy? So basically, you have a spread of signal through an internal nervous system. There are actual nerves in the heart, but also spread through the individual myocardial cells. Because remember, one myocardial cell, which branches, remember they branch, they look kind of like this. They have gap junctions via intercalated discs down to adjacent myocardial cells. So when you have a signal flowing in through this cell, it can pass directly through the gap junctions to the next set of myocardial cells. So information and conduction in the heart happens at two levels. Number one, through the conduction system, through the heart's nervous system, and conduction number two, through the myocardial conduction. So I call that myocardial cell conduction. This ensures that we have a stable rhythm that's responding to levels of CO2 in the body. So if CO2 goes up, that means you're using up more oxygen and spitting out more, your cells are using more oxygen, spitting out more CO2, and your lungs, you start feeling the need to breathe harder to get rid of that CO2. We'll talk about this in the respiratory system. So that's helping regulate conduction in the heart, but then you also have just the spread of current through individual cells. We talk about that in much more detail in Bio-18 at Merced College, so you'll be getting that talk when you get there. So an electrocardiography, or ECG, is a way to measure electrical signals through the heart. We also call it an electrocardiogram. And so what happens is you'll go into the doctor's office and they put, let me see if I have a picture. I do not, sorry. They'll put little leads on the surface of the body to record the electrical impulses as they are being conducted through the heart. These impulses are easy to measure, actually, using the little electrodes, because the electrical impulse is actually fairly large throughout the heart. And so by using the appropriate number of sensors, you can make an electrocardiograph of each chamber of the heart as a contraction occurs. So actually, I'll come back to this in a minute. So when we're looking at conduction through the atria, you'll see a little blip. So this is just the little blip conduction starting in the atria, right and left atria, and we call that the P wave. As the conduction spreads down to the AV node here, that sets off what we call the QRS complex, okay? So that's telling you about a huge spike of electrical activity that's going to be spread down to the ventricles. QRS includes the spread of the conduction through the bundle of His, out to the right and left ventricles through the Purkinje fibers. And then you have the reestablishment of what we call the T wave right here, where the ventricle is starting to go into systole. So you have the contraction or the systole here of the atria, which is the P wave, the spread of the information, which is QRS, okay, which then initiates the contraction or the systole of the ventricle. And then the T wave is the reestablishment of systole in the ventricles. So if we come back here, the P wave is associated with depolarization, or the contraction starting in the atria. The QRS is the depolarization of the ventricles, and the T wave is repolarization or reestablishment of systole. So repolarization is systole, And depolarization is diastole. Oh, so this is relaxation. This is contraction. So cardiac dysrhythmia is the abnormal heart rhythm, and this can happen for a lot of reasons, okay? It can happen when there's a complete heart blockage. So let's say, for example, there's a blockage of the coronary vasculature, okay? And the tissue of the heart's not getting blood, not having CO2 removed. That causes that part of the heart to not be able to contract anymore. Heart blockage, conduction blockage. A complete heart block happens when the AV node conduction starts producing that P wave and the QRS complexes, but the heart's not able to react, okay? And so cardiac dysrhythmia, there are a lot of different ways this can happen, but if there's that complete blockage where the AV node conduction, the P wave, the QRS complex, the T wave is not reestablished, typically what will happen is the individual will have an artificial pacemaker implanted, and sometimes they actually completely remove the AV node from operation. The pacemaker allows the pacemaker introduces that AV contraction and maintains a stable heart rate. Now, the conduction system of the heart is supposed to be maintaining bradycardia or tachycardia depending on what's happening. When you're sleeping, you're laying down, you're relaxing, all you need is a slow heart rate, anything under 60 beats per minute, because you're resting, your body's recovering from the day. We call that bradycardia. Tachycardia is when you have a rapid heart rate. It could be totally natural. You're out running a couple miles. That's going to induce tachycardia, and that's going to be over 100 beats per minute. That's the definition. Tachycardia is over 100 beats per minute. Can be totally normal. Now, if you have dysrhythmia brought on by, let's say, drinking too much coffee, then you would have caffeine-induced tachycardia. That's very uncomfortable. I don't like that so much. There's also sinus dysrhythmia. This is where the heart rate changes during your breathing cycle, and it's actually a little bit hard to detect. A doctor can sometimes detect it with a really good stethoscope. As you breathe in and breathe out, it changes your heart rate just slightly because of the size of your thoracic cavity. That's all we need to think about with that. Premature contraction, extrasystole. This is when you have usually it can be actually atrial or ventricular, and sometimes you have like thump, 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 and that just happens sometimes. Usually people can detect that because they will feel like they need to take an extra breath, because all of a sudden you have this dysrhythmia that interferes with circulation of blood out to the lungs. And then we have fibrillation. This can be bad because fibrillation is usually an additional systole that happens more than once. So it'll be like thump, 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 and then it skips a beat, right? That's really bad. This is when the cardiac muscle fibers actually are contracting without producing effective systole. And what that means is that the heart is actually kind of quivering, but not contracting and pushing blood around. And that makes for a very, very inefficient systole. So that can lead to heart failure. Atrial fibrillation is more common than ventricular fibrillation. Ventricular fibrillation is not good because that will actually stop heart rhythm, which means no heart contraction, which means you're going to pass out, right? So heart failure is the inability of the heart to pump blood to the body to sustain life. It can happen for a lot of different reasons, but heart failure is basically the terminal event of the heart at the end of an individual's life. It does lead to other failures in the system, like neural failure, circulatory failure, preceded by shock, and then you have failure. Right-sided heart failure is the failure of the right side of the heart to pump blood out to the lungs. The left side of the heart usually fails first before the right side. The right side of the heart will continue pumping blood out to the lungs. But if the left side can't pump blood to the system, blood will back up and lead eventually to right side heart failure. Left side heart failure is congestive heart failure. It's the inability for the left ventricle to pump effectively. Usually this is resulting from, they call it congestion of the systemic and pulmonary circuits. Basically, it's backing blood up from the atria to the ventricle out to the lungs. Actually, I should say ventricle to atria to the lungs. And this is usually preceded by mitral valve prolapse. So congestive heart failure is not a really pleasant way to go. Eventually, what ends up happening is individuals end up having circulatory problems, lots of edema or swelling in their extremities. They're very, very tired because you can't get blood out to the body. And eventually, congestion in the pulmonary and systemic circulation leads to individuals they pass out, they faint, they go unconscious, and eventually their heart undergoes full failure. Diseased hearts can be replaced through heart transplant. It's hard to find those. There are artificial hearts, although they are not very, there are some that work decently, but the problem that ends up happening with artificial hearts is that artificial hearts don't have the same degree of, I guess you would say, fine control with the vascular system. And so you can wire it up, but eventually there are blood pressure problems in the vascularization in the blood vessels that cause further disease down the line. So that's it with the heart for today.